Welcome to study session 3, Childhood Autism. Introduction. In this study session, you will be introduced to childhood autism, a pervasive developmental disorder that is defined by the presence of abnormal and or impaired development that is manifest before the age of 3 years. The disorder occurs in boys 3 to 4 times more often than in girls. In this study session, we will also be introduced to etiology of autistic spectrum disorder and attention deficit hyperactivity disorder. Learning outcomes for study session 3. When you have studied this session, you should be able to 1. Define childhood autism. 2. Explain the etiology of autistic spectrum disorder. 3. Explain attention deficit hyperactivity disorder. What is autism? Autism is a developmental disorder that is characterized by impaired development in communication, social interaction, and behavior. It affects the lives of many children and their families. The disorder typically has a chronic, unremitting course. It tends to affect more boys than girls. DSM-5 combines a group of disorders that formerly included autism, pervasive developmental disorder, not otherwise specified, Asperger's syndrome and sometimes Rett's disorder, and childhood integrative disorder are now referred to as autism spectrum disorders. The range of these disorders varies from severely impaired individuals that were formerly described as suffering from autism to other more high-functioning individuals who have abnormalities of social interaction but normal intelligence, who were described as having Asperger's syndrome. The ways in which autism spectrum disorders are exhibited can differ greatly. Additionally, autism can be found in association with other disorders such as mental retardation and certain medical conditions. The degree of autism can range from mild to severe. Mildly affected individuals may appear very close to normal. Severely afflicted individuals may have an extreme intellectual disability and be unable to function in almost any setting. Childhood autism symptoms. Profound problems with the social world. Rarely approach others. Pay attention to different parts of faces than do people without autism. Focus on mouth. Neglect eye region. This neglect likely contributes to difficulties in perceiving emotion in other people. The inability to relate to others is another central feature of autistic disorder. One view is that people with autism lack a theory of mind. That is, they fail to appreciate that other people have a point of reference that differs from their own. Understanding that other people have different desires, beliefs, intentions, and emotions, which is crucial for understanding and successfully engaging in social interactions, typically develops between 2.5 and 5 years of age. Children with ASD seem not to achieve this developmental milestone. The symptoms include communication deficits. Children with ASD evidence early language disturbances, echolalia, immediate or delayed repeating of what was said, pronoun reversal, which involves confusing the pronoun you with the pronoun I, refer to themselves as he or she. There is literal use of words, repetitive and ritualistic acts. Another defining symptom of autism is restricted, repetitive and stereotyped patterns of behavior, interests and activities. These odd preoccupations and rituals create social complications. Rituals such as flapping a string or spinning a top seem to serve no other function than providing sensory feedback or self-stimulation. Although it is not a part of the diagnosis, some people with PDD respond to auditory, tactile, or visual sensations in a highly unusual and idiosyncratic manner, become extremely upset when routine is altered, engage in obsessional play and ritualistic body movements, become attached to inanimate objects, e.g., keys, rocks. Diagnosis of autism. Early infantile autism was first described in 1943 by the psychiatrist Leo Kanner of Johns Hopkins University. Mental health professionals only recently recognized that the Viennese psychiatric and Asperger identified a very similar condition at virtually the same time as Kanner. One important difference, however, was that Asperger's patients exhibited higher intellectual functioning. The distinction between Kanner's and Asperger's patients was introduced into the formal diagnostic nomenclature in DSM-4. Asperger's disorder is now listed as a subtype of PDD. Descriptively, it is identical to autism, with the exception that the disorder involves no clinically significant delay in language. The new diagnosis for Asperger's disorders refers to people who show the symptoms of autism but do not have major problems in communication and generally function higher in other areas as well. Childhood disintegrative disorder refers to a poorly understood and somewhat controversial condition characterized by severe problems in social interaction and communication, in addition to stereotype behavior. Rett's disorder is a clearly distinct condition characterized by at least 5 months of normal development, followed by a deceleration in head growth, loss of purposeful hand movement, loss of social engagement, poor coordination, and a marked delay in language. Etiology of autistic spectrum disorder. Autism is a set of a wide variety of symptoms and may have many causes. Autism is thought to be a biologically based disorder. In the past, it was suggested that autism was a result of poor attachment skills on the part of the mother. Some risk factors for autism include high maternal age at the time of birth of the child, as well as maternal prenatal medication use, bleeding, or gestational diabetes. Other support of a biological theory of autism includes that several known neurological disorders are associated with autistic features. Autism is one of the symptoms of these disorders. These conditions include tuberous sclerosis and the Fragile X syndrome, that is inherited disorder, cerebral degenesis, abnormal development of the brain. Rett syndrome, a mutation of a single gene, and some of the inborn errors of metabolism, that is biochemical defects. Autism, in short, seems to be the end result of final common pathway of numerous disorders that affect brain development. Also, brain studies have demonstrated that persons with autism tend to have a number of abnormalities in brain size. Brain size is although of normal size at birth. Brains of autistic adults and children are larger than normal. Pruning of neurons may not be occurring. Overgrown areas include the frontal, temporal, and cerebellar, which have been linked with language, social, and emotional functions. Abnormally sized amygdalae predicted more difficulties in social behavior and communication. Genetic factors. Certainly, disorders such as the Fragile X syndrome and tuberous sclerosis, which are both associated with autism, are inherited. There are many families with more than one child with autism, where the autism is not clearly due to another cause. Recent studies have found that the gene for at least one kind of familial autism may be on chromosome 13. In some families, autism seems to be passed from generation to generation. In other families, autism is not found in prior generations, but affects multiple siblings, brothers or sisters. The results of this research make it likely that at least one autism gene will eventually be found. Heritability estimates of around 80 twin studies revealed 47 to 90% concordance rate for MZ twins, 0 to 20% for DZ twins. Genetic flaws like deletion on chromosome 16. However, the majority of individuals with autism do not have a strong family history, which supports the premise that environmental or a combination of environmental and genetic factors contribute to the development of autism. In this context, environmental is meant to indicate any non-genetic factor, including infections, toxins, nutrition, or others. Intensive behavioral modification using operant conditioning techniques called applied behavior analysis (ABA) is the most promising approach to treating autism. ABA therapists focus on treating the specific symptoms of autism, including communication deficits, lack of self-care, skills, and self-stimulatory or self-destructive behavior. Intensive operant conditioning produces dramatic and encouraging results. Parent training and education. Pivotal response treatment. Focus on increasing child's motivation and responsiveness rather than on discrete behaviors. Joint attention, intervention, and symbolic play used to improve attention and expressive skills. Medications used to treat problem behaviors. Haloperidol, antipsychotics. Medications reduces aggression and stereotyped motor behavior, but does not improve language and interpersonal relationships. Developmental disorders. One of several disorders that interrupt normal development in childhood. They may affect a single area of development. Specific developmental disorders or several pervasive developmental disorders. DSM-5 splits childhood disorders into two: neurodevelopmental disorders and secondly, disruptive impulse control and conduct disorder. In the first study session, we discussed the difference between externalizing and internalizing disorders. In today's lecture, we will examine an example of an externalizing disorder: attention deficit. Attention deficit hyperactivity disorder. Everybody probably knows at least one child considered to be hyperactive, a child who is overly impulsive, has trouble attending to the task at hand, and in general is exceedingly overactive. ADHD has also been called childhood hyperactivity, hyperkinetic syndrome, attention deficit disorder, and minimal brain dysfunction, to name but a few of the more common terms. Modern scientific interest in what we now know as ADHD began in the 1940s with the work by Alfred Strauss and his colleagues in a series of studies. Strauss isolated a number of characteristics which believed could discriminate between groups of mentally retarded children with and without brain damage. Associated with brain damage were aggressiveness, impulsivity, distractibility, and hyperactivity. Hyperactivity was seen as the most valid indicator of brain damage, and so it became widely accepted for many years that children with hyperactive behavior patterns were also brain damaged. The term minimal brain dysfunction was widely used to identify these children. Future research failed to find the link between hyperactivity and brain damage. Most children suffering brain damage do not develop hyperactivity, and it's been estimated that fewer than 5% of hyperactive children suffer from brain damage. During the late 60s and early 70s, the focus shifted to the attentional qualities of the disorder. Virginia Douglas and her colleagues at McGill University demonstrated the marked attention deficit seen in these children. Douglas argued that the major deficit was the inability to stop, look, and listen. In the late 70s, the focus broadened. Research was indicating that the problem went beyond mere attention deficits. People like Susan Campbell and Charles Cunningham conducted a number of studies on parent-to-child interaction. It was found that the hyperactive children were non-compliant, attention-seeking, and aggressive, and in need of ongoing supervision, and the mothers were overly directive, negative, and less responsive to the child in general. Thus, researchers included social variables into the increasingly complex picture. Compliance and aggressiveness gained diagnostic importance. Core features of ADHD. Inattentiveness is a key symptom of ADHD. Difficulties in attention can take various forms: trouble orienting to stimuli, failure to even detect stimuli, response to the wrong aspects of a stimulus or to an entirely inappropriate stimulus, failure to sustain attention to task-relevant stimuli. While inhibiting responding to no relevant stimuli, they are easily distracted or short attention span. In the home, failure to complete chores, homework, etc., to listen to directions, to play for prolonged periods without supervision or attention from others. At school, problems with attending to the teacher and completing in-class assignments. The child is often distracted by other events, what other kids are doing, what's happening outside the window. However, they may attend at length to these non-relevant stimuli, so the problem is more than just a short attention span. It often seems to be a problem of allocating the right amount of time and focus to the appropriate information. Impulsivity, or the failure to inhibit responding, has also been identified as a primary characteristic. This can take various forms: quick responding with numerous errors, do not stop to think about consequences of their actions, place themselves in dangerous and risky situations, fail to fully appreciate all aspects of instructions given to them, more likely to respond aggressively, verbally and physically, when frustrated or emotionally hurt by others, and they do not consider the impact of their actions or statements on others. Such actions can lead others to see such children as immature and to their being shunned by others. The impulsive child will also experience more punishment than normal children. 2. Overactivity has also been identified as a key feature of ADHD. The typical picture of the child is always on the move, with no apparent regard to rules, directions, or the like. These then are the core features: inattentiveness, impulsivity, and hyperactivity. The picture is far from clear. However, these characteristics don't always hang together. They often fail to correlate with one another. Etiology. Numerous etiological factors have been identified over the years. Research often produces conflicting findings. Biological factors. As we've already noted, ADHD was once thought to be the result of brain damage. Much research has been conducted to find specific organic or neurological factors that could account for ADHD. 1. Prefrontal cortex abnormalities. This part of the brain plays an important role in inhibiting, modulating, planning, and regulating complex behavior, such as planning for the future and following instructions. People with damage to this part of the brain often exhibit ADHD like symptoms: inattentive, easily distracted, impulsive, restless, etc. It has thus been hypothesized that ADHD may be caused by abnormalities in this part of the brain. Nevertheless, there is presently no clear direct evidence to support this hypothesis. 2. Neurotransmitter abnormalities. ADHD children respond to stimulants with reduced ADHD symptoms, a seemingly paradoxical effect. The behavior most improved attention. For a number of years, it was thought that this effect indicated abnormal biochemical processes, especially deficiencies of the neurotransmitters norepinephrine and dopamine. More recent research, however, shown that ADHD children do not respond differently to stimulant drugs than normal children. 3. Neurological immaturity. An alternative hypothesis is that maturation of central nervous system structures is delayed rather than actually damaged. Observations of ADHD children make this hypothesis appealing. The children do seem to be acting in immature ways. Some studies of brain activity, especially CNS structures underlying attention and response inhibition, also suggest immature processes. 4. Genetics. Studies have found a higher incidence of ADHD in the biological relatives of hyperactive children than in the population at large. This seems to be true even with ADHD children who are adopted. Similarly, there is a high concordance rate for twins. When one twin has ADHD, the other has a higher than average chance of also having ADHD. 5. Environmental factors. Various toxins and allergy-producing substances in the environment have been identified as possibly relevant to the etiology of ADHD. Lead is found in many substances: paint, automobile. A number of studies during the 70s noted an elevated level of lead in the blood of ADHD children. 30 to 35% of children with elevated blood levels were also hyperactive. Food additives and refined sugars. Food additives, e.g. artificial food colorings and flavorings, and refined sugars, has been linked to cause ADHD. Various other environmental factors have been suggested, including low-level X-rays emitted by fluorescent lights, maternal smoking during pregnancy, and maternal alcohol consumption during pregnancy. Psychosocial factors. Some researchers have claimed that hyperactivity is the result of poor parenting skills, inconsistent rules, over-reliance on punishment, excessive and ill-timed commands. Indeed, treatment programs which teach parents more effective parenting skills have had significant success. In addition, inconsistent or chaotic rules, excessive punishment, and the like are possibly a result of ADHD. Parenting styles can have an important influence on maintaining or even aggravating the ADHD symptoms. Summary of study session 3. In study session 3, you have learned that autism is a developmental disorder that is characterized by impaired development in communication, social interaction, and behavior. It affects the lives of many children and their families. The disorder typically has a chronic, unremitting course. It tends to affect more boys than girls. DSM-5 combines the group of disorders that formerly included autism, pervasive developmental disorder, not otherwise specified, PDD, NOS, Asperger's syndrome, and sometimes Rett disorders, and childhood integrative disorder are now referred to as autism spectrum disorders. 3. Developmental disorders are several disorders that interrupt normal development in childhood. They may affect a single area of development. Specific developmental disorders or several pervasive developmental disorders. ADHD children are considered to be hyperactive. A child who is overly impulsive has trouble attending to the task at hand and in general is exceedingly overactive. We have come to the end of study session 3.